Good evening, students. Today we are going to study about movement disorders. As the name say, movement disorders, that is this is something related to abnormal movement, or there is disruption of, if I can say, motor function. Fine. So this is movement disorders. They are given this. There is another term for it which is called as basal ganglia disorders. Fine. Or they have also been given as kinetic syndromes. So these are the different name given to movement disorders. So movement disorder is the term which is used for abnormal movement or disruption of motor function. Now these kinetic means motion syndromes. They are of two types. We have already discussed about it. There is hypokinetic syndromes and hyperkinetic syndromes. Now if hypo means when there is restriction to the normal range of motion, as we have seen in Parkinsonism condition, where there is restriction in the range of motion or slowness of movement takes place, which is basically for in the cases of akinetic rigid syndromes. Fine. And hyperkinetic syndromes are basically, they are unwanted movements. When we are about to do a normal voluntary movement, there are unnecessary unwanted movements which accompany. They are abnormal movements which accompany the normal range of motion. That is called as hyperkinetic syndromes. Fine. So there is an hypokinetic syndrome and hyperkinetic syndromes. Now since they are called as basal ganglia disorder, in the previous video we have already discussed about basal ganglia and its nucleus. The stratum, which is made up of caudate nucleus and putamen. Then globus pallidus, which is made up of globus pallidus internus and globus pallidus externus. The third nucleus is the subthalamic nuclei. The fourth nucleus is substantia nigra, which is this yellow structure. So these are the structures, or these are the nuclei of basal ganglia. We have also studied about the direct and the indirect pathway of movement. I am just showing you again. This is the direct pathway of movement. If you can see the direct pathway, it causes movement, it facilitates movement. The thalamus give excitatory thalamocortical fibers and releases glutamate, which causes the movement to happen. Whereas you have seen the release of dopamine basically inhibits the inhibition by the globus pallidus internus and substantia nigra par reticula. It inhibits the inhibition, whereas this brings about the motion. In the indirect pathway, we have seen that it basically causes inhibition of movement. There is inhibition of movement which happens. Fine. And herein we see that there is inhibition wherein there is hyperactivity of dopamine will cause the inhibition of globus pallidus externus, subthalamic nuclei, which causes the further inhibition to the thalamus so that no movement takes place. Now why we are discussing again about the direct and indirect pathway? Because these both pathway are responsible for movement, and we are studying about movement disorder. Now we know that there is in Parkinson, there is we have used the word here, hypokinetic syndrome, hypokinetic movement. When hypokinetic movement is possible when the direct pathway is less active, and indirect pathway becomes more active. So what will happen is is decrease in movement. Will happen. Fine. Whereas in hyperkinetic syndrome, there is overactivity of direct pathway. There is overactivity of direct pathway, and as a result of which there is unwanted movements. There is unwanted and abnormal movements which are happening along with this. So this is basically, this pathway is very much important, the direct and the indirect pathway, because herein this is less active, and herein in hyperkinetic syndrome it is overactive. Now why we are studying all this is because there is some relationship, that is clinical and pathology correlation between this. That is, we have got substantia. I'll be telling you about these nuclei. That is, which nuclei? Basal ganglia nuclei. That is, we have already seen that it is substantia nigra, and this substantia nigra, any defect of substantia nigra results in Parkinsonisms. Fine. Then there is subthalamic nuclei. Any defect or degeneration of subthalamic nuclei results in a movement disorder which is called as hemiballismus. Defect of caudate nucleus results in chorea, and defect of putamen results in athetosis, and defect in cerebral bellar cortex, which is responsible for our correction of movement, results in myoclonus. Now these nuclei, that is why it is called as basal ganglia disorders. These are movement disorders or basal ganglia disorders. The reason why it is given so is because of its correlation. Clinically, the presentation, how this syndrome is called, and the area or the nucleus which is concerned. Fine. So we will be discussing in detail about these conditions. Fine. These are all myoclone or are kinetic syndrome. In hypokinetic syndrome, we have already discussed Parkinsonism, and that too in very much detail. Now we will be discussing about these 4 other movement disorders or kinetic syndromes. Fine. Now let us see what is chorea. For your proper understanding, what I have done is I have already floated some videos in your WhatsApp group so that you understand these conditions. There are 4 videos of chorea, athetosis, hemiballismus and myoclonus. I have already floated in the WhatsApp group so that you understand the condition of the patient, how the patient presents. The presentation of the patient is clear. Fine. Chorea basically means dance-like movement. Fine. It is called as dance-like movement. Now this is basically, and if I can say, it is an hyperkinesia or hyperkinetic movement. Fine. Which is aimless and irregular and involuntary. That is, it is not under patient's control. Fine. And purposeless. Okay. And it is a jerky and basically random movement. Now I have given so much terms to it. It is a hyperkinetic movement or hyperkinetic disorder. I can use the word disorder here. Fine. In which is aimless, without any aim. It is irregular. It is involuntary. It is purposeless, jerky and random movement of basically the distal part of upper limb, distal part of upper extremity. It may also involve face, that is basically tongue, lips and grimace. Grimacing is common, and it involves one side of the body, one half and half of body, and it may run to whole body. That is one side, it may involve one upper limb, and then it may go to the upper limb also, the second upper limb, second half. But the thing is that it will increase during activity and during tension, or if I can say stress, but it disappears in sleep. It disappears in sleep. Fine. So this is basically, if I can say, it's an aimless movement, and it is very random movement. It is jerky and irregular, and the movement will be very much in the irregular, and whenever the person is about to do any voluntary movement, then this will happen. This will be more easily visible. Fine. Now there are this is also, vocal cords are also involved here. Important thing is vocal cord is also involved. Now vocal cords, then there will be disruption in phonation. They will find very difficulty in phonation. They will not be able to speak properly, but they will all disappear. This all will disappear in sleep. It will all disappear in sleep. So we have got certain tests. One is called as piano playing fingers test. That is, if we ask the patient to try to touch or hold the therapist's hand, and the fingers will run like this. The finger will start running like this. Fine. This is called piano. He will be trying to grab the finger of the therapist, but he will not be able to do it. Why so? The fingers will be, it will seem like the fingers are playing piano. There is another test which is called as milkmaid grip. The second test is when the person is asked to lift or grab the finger of the therapist, he will grab it like this. Can you see this image? It will grab it like this. So it is like milkmaid's grip. He will grip it like this. Fine. The third is there will be blinking will be more often. Blinking increases, and when you there will be decrease in tone to passive movements. Fine. So if I can just give you a revision for chorea, it is a dance-like movement, and it is a hyperkinetic disorder which is aimless, irregular, involuntary, purposeless and jerky movement, which is and happens in the distal part of the upper limb, but face are also involved, tongue, lips. Face shows grimacing. Fine. It starts with one half of the body and then covers the opposite side also. It increases with activity, with tension and with stress, and disappears in sleep. Vocal cord may or may not be involved, which causes disruption in phonation. And there are certain tests which can be done, which is called as milkmaid test, piano playing finger test, and blinking increases and increase in tone to movement or passive movement. Decrease in tone to passive movement. Fine. Now this in brief is about chorea. Fine. Now we will study about athetosis. Now athetosis is since the chorea was like a dance-like movement, and I have not told you about causes. The causes over here was the chorea was any degeneration of caudate nucleus, or it can be because of drugs, which is psychotic drugs. It can be vascular degeneration of caudate nucleus of basal ganglia. It can be any hemorrhagic condition of basal ganglia. Any of this condition can result in chorea. So the causes can be, the most common degeneration of caudate nucleus is called as Hutchinson's chorea. It is also called as Hutchinson's chorea. Fine. So this is, it was been discovered by Hutchinson, Dr. Hutchinson. So that is why it is called as Hutchinson's chorea. Fine. So there is nothing you can write about, at least 5 to 10 points about Hutchinson's chorea. It is a dance-like movement. Now the next thing which we will be doing is about athetosis. Now in athetosis is basically the person cannot stand. It is means he cannot maintain a fixed position. He cannot maintain a fixed position. Cannot maintain. Okay? He cannot maintain a fixed position. That is, the movement will be, the limb will be continuously moving. Okay? The limb will be continuously moving. Okay? So the word which we use over here is writhing, and it is writhing movements are there, or we can say twisting movement, involuntary twisting or writhing movements, and it is of large amplitude as compared to the chorea movement, and it is of course the extremities and the face are involved here also. And this is a typical movement. If I want to show you is, now the movement starts with, like, it will be the extension of the finger, flaring of the finger, and you can see extension of the wrist, and the forearm is going into pronation, whereas flexion of the finger, flexion of the wrist, and flexion of the wrist and fingers, along with the supination of the forearm. Can you see the movement which is happening? This is the movement. This is a large amplitude. The chorea was just this movement, whereas this is, the amplitude has increased. It has involved the fingers, it has involved the wrist, and it has involved the forearms. But again, you can say the distal extremity is only involved. The distal extremity is only involved. The face may be involved in this again. And here in this is also a movement which is which starts with one body part, and then it can move to the other body part, like from one side of the hand to the opposite side of the hand, and it disappears in sleep. This also disappears in sleep. So they are much slower. They are of larger amplitude, but they are much slower than chorea movement. So chorea movement was continuously this movement, whereas this is a slow movement. This is a slow movement, but this is also a continuous movement. Can you see? This is a continuous movement, but this is a slow movement. This movement is fast, rapid, and these all happens in the distal extremity or in the face. There will be in the face twitching movement will be there, twisting movement, like similar to that of wry neck. The head or takes place, and in dependent position the this movement takes place, and it starts with one side of the limb, it goes to the opposite side. The difference only is it is slower than chorea, and it is of large amplitude, and it is a twisting movement. Fine. Now the next is now we basically say this as choreoathetosis. We basically, you will find we use this term more when we are not able to decide whether it is a slow amplitude or sometimes both. Then we use the term called choreoathetosis. Now this term we will find most common in CP kids diagnosis, when we write when there is a perinatal injury to basal ganglia. Fine. Then we have athetoid type of CP, and you can see this is the choreoathetoid type of CP takes place. Their perinatal injury is to caudate nucleus and putamen. Fine. So there you will find that chorea and athetosis, and sometimes when it is very difficult to make a distinction whether it is chorea or athetosis, then because of the movement in the amplitude is the only main significant factor which helps us to distinguish between the two, we write it as choreoathetosis. Now the next is term is, we say it as ballismus. Ballism. Now ballism is basically a term, Greek term of jumping movement. It is called jumping movement. Whereas we have a term called hemiballismus. Now this is basically, we use the term as flinging, flailing and swinging movement. This is the terms we use. Flinging is basically very forceful, violent. Flailing means something thrashing, like we are thrashing clothes. Fine, how we thrash clothes on the rock. Okay, that is called as flailing movements. And swinging, you all understand, swinging of the arm. Fine. So this is basically a forceful, violent thrashing movement of the arms. Can you see? Now here the limbs which are involved is proximal joints are involved. Fine. Proximal joints are involved. There is sparing of face or trunk, whereas proximal joint, shoulder and hip joint is more involved over here. Now this is a violent activity, and because of this the patient may sometimes end up in a fatal condition, because he is continuously in interrupted movement. And this hyperkinetic movement is, you all understand, because we have already discussed, because of subthalamic nuclei, degeneration of subthalamic nuclei. Because of this is a flinging, flaring and swinging involuntary movement which happens, an involuntary movement which is continuously happening, okay, which is without any patient's control. So it happens because of the degeneration of subthalamic nuclei, and it occurs in the proximal joint, similar to that of shoulder or hip, sparing the face and the trunk, and it is a violent and a fatal condition. It is very violent and a fatal condition. Now if we try to compare regarding this chorea, if I can say hemiballismus and athetosis, we try to compare the three of them. We see that they all are involuntary movement. We can say all the three are involuntary, with that is, whenever a voluntary movement takes place, they are not under control. This will happen. This is a kind of a slow movement, whereas these both are rapid movements which happen. Chorea is a rapid movement, hemiballismus is a rapid movement, whereas this is a slow movement. Now we have seen this is a dance like movement, and this is something called flinging, flaring and swinging movement, where this is a twisting body movement. Twisting movement takes place over here. Fine. Here you find that proximal limb is involved. Here also proximal limb, here distal limb is involved, that is hands, distal limb is involved, and herein proximal limbs are involved. Face is involved, here no involvement of face takes place. This is a fatal condition, whereas they are non-fatal in condition. So this is how you can distinguish between chorea, hemiballismus and athetosis. Fine. The last thing which will I like you guys to understand is myoclonus. Now this is basically a defect of cerebellar cortex, but this is it is a single twitch like movement. It's an involuntary, and it is, again if I can say, involuntary, rapid twitch like or lightning like contraction, involuntary contraction of a muscle or all motor unit of a muscle or group of muscle. But it is symmetrical. Symmetrical is the word. It happens in both sides. If quads are getting, there is a twitching of the quads, it will be twitching on both sides, left and right, both side quads will be there. This is called myoclonus. This is called myoclonus. Fine. But this myoclonus is of two types, which is physiological and pathological. Now physiological is which will happen in the eye. We get this twitching in the eye. Fine, this is called physiological, which normally happen in the eye, or this is called twitching movement, or hiccups are sudden twitching movements or clonic movements happening on the in the vocal cords. This is called hiccups, which is happening, or which like those in sleeping, during sleeping there is some kind of a jerky movements which happen. They all are physiological movements that it happen to everybody. Okay, everybody. Whereas the pathological is in cases of epilepsy. It happens, it becomes a sign of epilepsy. This condition is called as myoclonic epilepsy, myoclonus epilepsy, or tonic clonic seizure. So basically, pathologically, this clonus is related to epilepsy, and we will be dealing in detail. I will be taking a separate lecture on this, on epilepsy and seizures. I will be taking this, but you should have an idea that myoclonus are physiological, which happen normally also in a condition called hiccups or twitching of eye or during sleep, whereas pathological it is in cases of epilepsy. So today what we have learned? Now we have learned today about movement disorders. Now movement disorders, they are also called as the basal ganglia disorder. Fine, they are also called as basal ganglia disorders, or they are also called as kinetic syndromes. They are basically abnormal movement or disruption of motor functions. They are of two types: hypokinetic movement and hyperkinetic movement. Hypokinetic is similar to that of Parkinsonism or akinetic regent syndrome, whereas hyperkinetic movement is abnormal unwanted movement along with the voluntary action which we are doing. Now the cause is the direct pathway is less active and the indirect pathway is more active in hypokinetic syndrome, resulting in decrease in movement, whereas overactivity of direct pathway results in unwanted movement or increase in movement. So we understood this through a direct and indirect pathway. Fine. Then we also saw the relationship between the nuclei and which kind of a movement disorder they are causing. Like substantia nigra or degeneration at the level of substantia nigra is causing Parkinsonism. Degeneration at subthalamic nucleus is causing hemiballismus. Degeneration at caudate nucleus is called as chorea. Degeneration at putamen is causing athetosis, and degeneration at cerebellar cortex is causing myoclonus. So this was your clinical and pathological correlation. Now we were discussing about chorea. Chorea is basically a dance-like movement, and it is a hyperkinetic disorder which is aimless irregular, purposeful, jerky movement, and which is caused due to degeneration of caudate nucleus. The reason can be because of psychotic drugs, or it can be a vascular injury to the caudate nucleus, or a hemorrhage at the level of basal ganglia concerning with the caudate nucleus. Now here in the characteristic features is that the distal part of the upper limb is involved, upper extremity, that is hands are involved. Face, there is tongue, lips are involved, grimacing of face takes place. It increases with activity and tension and sleep and disappears in sleep. Vocal cords are disrupted, so there is difficulty in phonation. Which happens. Fine, so these all hyperkinetic syndromes, they intervene in voluntary movements. Remember that. Intervene in voluntary movements. So that is piano playing movement is the test for it, piano playing movement. That is, and the second test which we discussed was about the milkmaid grip, and there will be increase in the blinking rate, and then there is hypotonia, or there will be decreased resistance to the passive movement. The second condition which we studied was of athetosis, which is called as the patient cannot maintain a fixed position. The limbs continuously keep on moving. So it is called as the writhing twisting movement. Okay, it is writhing, twisting movement, and it is slower than chorea, but it is of larger amplitude, where distal extremity and face are involved. Distal extremities, portion of the fingers, hand, toes, face and neck are involved, and it involves basically a combination of movement of flexion, extension, abduction, pronation, supination at varying degree. That is hyperextension of fingers and wrist with pronation of forearm, followed by full flexion, wrist flexion and supination of forearm. Fine. They all disappear in sleep, and they start with one side of the body and continue with the other side of the body. So there is another term which is called chorioathetosis, which is seen in perinatal injury to the basal ganglia, which is seen in children, and they have been diagnosed as athetoid CP. So this is the condition which we all discussed. Next we came to ballismus. Ballismus is jumping movement, and hemiballismus is half side of the body. When half side of the body is showing something forceful and violent, thrashing movements of arms or hips, this involuntary and continuously involuntary movement which is happening at the proximal shoulder and hip, and is violent and fatal due to degeneration of the subthalamic nucleus, is called as hemiballismus. Here there is sparing of face and trunk takes place. There is sparing of face and trunk. Then we discussed how we can distinguish between chorea, hemiballismus and that of athetosis. Now we saw it is athetosis is a slow movement, where these both were the rapid movements, and this is a dance like movement, and there herein this is a violent flinging, flaring and swinging movement, whereas this was a kind of a twisting and writhing movement. Fine. This happened in the proximal, whereas these both were distal. Limbs were involved. No face. Here there was face, no face, and here face again was involved. You can see there is this movement is non-fatal, whereas hemiballismus is a fatal condition. Fine. The last thing which we discussed was of myoclonus. Now this is a single, if you can say, cause was a defect at the level of cerebral cortex, and it is a symmetrical, that is, it happens on both the sides. The word which is important over here is it is symmetrical. Fine. And it is a single movement only. It is a single twitch like movement, like a single twitch of brief, rapid, involuntary twitch like lightning contraction of a muscle or a group of muscle or a portion of a muscle. Fine. And it is, if I can say, quicker than chorea. It is much quick than chorea movement. Fine. And herein the muscles of both the extremity and the trunk, both are involved, and the facial muscles are also herein involved. The facial muscle is also involved. Facial and tongue muscle is also involved. There are two types. They are physiological as well as pathological. Physiological is in the condition of hiccups, or you can see in normally this happens in we say it as hypnic jerks during the period of sleep. This happens, or twitching of eye, which happens, whereas this pathological is myoclonic epilepsy or tonic-clonic seizures. This becomes a pathological condition. Fine. This is all about the kinetic syndromes or the disorders of basal ganglia or the movement disorders, which is there in your syllabus. I have not herein discussed about cerebellar ataxia, because this topic will be coming in your next semester. So I will be dealing that as a separate topic. So herein I hope you understood this topic, and I'm looking forward for your doubts and your queries. Thank you.